Thanks very much for joining this VetSpace module on tips for smooth and stress-free anaesthesia, which has been kindly developed for us by Dr. Matthew Gurney. This is the second module that Matt has developed for us for VetSpace, but for those of you who haven't seen his first module, Matt is a Liverpool vet school graduate and a trained anaesthetist working in referral practice in the UK. He has a wealth of veterinary anaesthetist and analgesia knowledge to share with us, but his main interests lie in pain management in both the acute and chronic setting. Matt is a European veterinary specialist in anaesthesia and analgesia and a Royal College of Veterinary Surgeons recognised specialist. So we're very lucky to have him to share some of his thoughts with us today, and over to you, Matt.
This module on smooth and stress-free anaesthesia will give you a greater understanding of some of the fundamental principles of anaesthesia. These will be illustrated with examples to make that next anaesthetic more relaxing for all involved, giving you the confidence that you're doing the best for the pet. Let's start with balanced anaesthesia. Anaesthesia is often referred to as a triad of sleep, analgesia, and muscle relaxation. No one drug can achieve all three of these, hence we use a combination of drugs. Of course all drugs have side effects, and so the aim of balanced anaesthesia is to use a combination of drugs to achieve sleep, analgesia, and relaxation without relying heavily on one particular agent and running the risk of adverse effects of one drug. The adverse effects of anaesthesia are predictable based on our knowledge of the drugs we use day to day, with common adverse effects including hypotension, hypothermia, and hypoventilation. Acepromazine provides sedation and muscle relaxation, but no analgesia, so we need to use it in combination with analgesics for surgical procedures. When used in conjunction with opioids, we see improved sedation with acepromazine, hence its use in this combination. The disadvantages of acepromazine are vasodilation, which causes hypotension, so we're always looking at ways to reduce our dose of acepromazine, or perhaps include alpha-2 agonists as an alternative. The alpha-2 agonists, medetomidine and dexmedetomidine, provide all three of our components of a triad of anaesthesia: sleep, analgesia, and relaxation. The analgesia is dose dependent and doesn't last as long as the sedation, which is why for surgical procedures we use alpha-2 agonists in combination with opioids. Disadvantages seen with alpha-2 agonists are focused on the reduction in cardiac output we see from the bradycardia, decrease in contractility, and increase in peripheral vasoconstriction. Fit and healthy patients with no cardiac disease can tolerate these drugs well, and the alpha-2 agonists are first-line pre-medication in my clinic for these cases. A good pre-med forms the basis of the subsequent anaesthetic. If 30 minutes after an intramuscular pre-med the dog jumps out of the kennel, we know this is not going to go well. Our pre-med is tailored to the individual patient and should provide sedation, anxiolysis, and analgesia appropriate to the procedure. Our main options for pre-medication in dogs and cats are opioids in conjunction with either acepromazine or an alpha-2 agonist. In my view, acepromazine is not particularly effective in cats, and I tend to use alpha-2 agonists for cats over acepromazine. Click on the next slides for pre-medication and opioid options in dogs. Let's consider an acepromazine opioid pre-med that has a poor effect. After 30 minutes, the dog bounces out of the kennel. 30 minutes is an adequate amount of time for onset of acepromazine, and being a long-acting drug, we don't really want to top this up. Despite a poor sedative effect in this case, in combination with other anaesthetic agents, you will see the vasodilatory effects causing hypotension, which we want to avoid. If you can place an IV, then an additional dose of opioid may help, you can top up methadone or buprenorphine without fear of adverse effects. I always ask myself at this point whether we can use medetomidine or dexmedetomidine in this patient. If there is no cardiovascular disease, then you can also use an alpha-2 agonist, either IM or IV, for a greater sedative effect. Whichever premed we decide to use, we should always give consideration to duration of action. Acepromazine generally lasts 6 to 8 hours. The alpha-2 agonist duration of action is dose dependent. The lower doses in the table for dogs and cats are likely to provide sedation for approximately 30 minutes, with higher doses lasting beyond an hour. We are aiming to use a premed that will last for the duration of the surgery and possibly into recovery, as some degree of anxiolysis in recovery is desirable. Within our consideration of balanced anaesthesia, we should consider multimodal analgesia and preventive analgesia. Preventive analgesia broadens the concept of preemptive analgesia in light of increasing knowledge to consider the influence of multiple factors on the generation of central sensitization, with the aim of attenuating the impact of noxious pre, intra, and postoperative stimuli. When considering analgesia for surgery, we need effective analgesics, provided for the duration of the pain. Our main components of multimodal preventive analgesia are opioids, non-steroidal anti-inflammatory drugs, and local anaesthetics. Other drugs which will augment our analgesia are the alpha-2 agonists and ketamine. For safe anaesthesia, I would recommend incorporating the use of a checklist into your anaesthetic practice. Work in human and veterinary anaesthesia has demonstrated a reduction in error rates when checklists are implemented. Typical problems documented in a veterinary hospital were closed APL valve post-machine check, esophageal intubation, and medication errors. In the first stage of this study, the incidence of errors and type of errors were recorded. In the second stage, once methods were put in place to reduce errors, the study was repeated. In period 1, there were 74 incidents at a rate of 3.6%. In period 2, there were 30 incidents, which is a rate of 1.4%, approximately an error reduction rate of a half. So what measures were put in place to reduce these errors? A checkbox was added to the GA record to show that the APL valve had been checked. A technician checked tracheal intubation, and the name of the medication was read aloud prior to administering it. The checklist I recommend you take a look at is available free of charge on the Association of Veterinary Anaesthetists website. It's a good place to start, and I would suggest you try it and modify it to your individual practice needs, as we have done in our hospital. In this case of a cat requiring anaesthesia for esophageal tube placement, we have a number of considerations. I've chosen an intravenous premed of medetomidine, ketamine and butorphanol. We already have IV access in this cat. This premed will actually enable tracheal intubation at this dose used, as one of our requirements is to protect the airway during O-tube placement. This combination of drugs will give excellent sedation and analgesia for a minor procedure such as this. Once intubated, if required, we can add a low dose of isoflurane to maintain our anaesthesia, but with our vaporizer set right down at 0.5%. Hemodynamically, we know that the alpha-2 agonist will cause bradycardia, approximately 90 beats per minute in this cat. In vivo, ketamine actually has very low myocardial depressant effects and can be useful for maintaining blood pressure. So we've considered how premedication fits within balanced anaesthesia, and let's turn now to the role of induction agents. The most common induction agents we're using are propofol and alfaxolone, although I know some people are using ketamine and a benzodiazepine combination as their induction agent. Regarding propofol and alfaxolone, this brings us back to balanced anaesthesia, where our aim is to use small amounts of individual drugs to overall decrease the adverse effects seen with using a big dose of just one drug. And really, we just want to use enough drug to facilitate tracheal intubation with either our propofol or our faxalone, and we're going to give these drugs very slowly to effect. Both our faxalone and propofol cause unconsciousness with excellent muscle relaxation. However, neither provide analgesia, hence the role of our pre-medication. On the negative side, the main effects we aim to avoid are hypotension caused by vasodilation and post-induction apnea caused by higher doses. With each of these in mind, the key here is slow administration. In this case, we are using alfaxalone. We've calculated a dose of 0.5 to 1 mg per kilogram based on the fact that this dog is very well pre-medicated with dexmedetomidine and methadone. We give 0.5 mg per kg slowly over 30 seconds. We then wait another 30 seconds for the drug to circulate from the cephalic vein to the brain before attempting intubation. Without this wait time, we may end up giving more drug and running the risk of post-induction apnea. Remember, when I say slow IV administration of your induction agent, I actually mean super slow. Watch the clock. You'll be surprised how quickly you usually give these drugs. Okay, post-induction apnea is really annoying. We worry about our patients during this period, and they take longer to transition to volatile agent. So what's my approach? I attach the breathing system and deliver 100% oxygen. This will be enough fresh gas flow to deliver oxygen to the lungs and maintain saturation, even during that apneic period. If you have pulse oximetry, you can use this to determine that the saturation is actually okay whilst we wait for the dog or the cat to breathe. Don't turn your volatile agent on yet, only do this once they start to breathe. Remember, the slower we give our induction agent, the less likely it is that we encounter post-induction apnea. In this video, before we turn the isoflurane on, we are checking from the rebreathing bag and from the capnograph that the dog is breathing. Next, we apply the pulse oximeter, as this gives us a really quick verification that everything is okay. Of course, at this point we should also palpate a pulse, as a second check prior to switching on our isoflurane. Looking from a patient safety point of view, how do we know we've intubated the trachea? Confirming tracheal intubation should be the first thing we do after induction, and you will save valuable time and lots of stress with these methods. The gold standard method is capnography, so if you have capnography, then ensure it is switched on prior to induction, as in the previous video. As soon as you see the end tidal CO2 on the capnogram, you can relax. Of course, you can directly visualise the ET tube within the larynx, but what about those patients with tons of soft tissue in the pharynx where you just can't get a good view? Do not push on the chest to confirm. If this is a sick dog with a full stomach and you make it regurgitate from that pressure of pushing, then they risk aspirating stomach contents into the lungs, which is a disaster. You can palpate the neck. You should feel the trachea. If you feel 2 tubes in the neck, then the esophagus has probably been intubated. Another easy method is to auscultate both sides of the chest with a stethoscope whilst an assistant squeezes the rebreathing bag, and you should hear breath sounds clearly on both sides of the chest. Once we've intubated the trachea, we want to check the integrity of the ET tube seal. This is for 2 reasons. 1, we want to avoid environmental contamination with volatile agent, and 2, we want to ensure that the airway is protected in the event that the patient regurgitates. Many more of our patients reflux or regurgitate than we actually realise, especially the sick ones. Make this standard practice for every case so you avoid running these risks. Another consideration with a leaky ET tube is that your patient will not be receiving the volatile agent percentage that we wish to deliver, and this will affect the plane of anaesthesia. To do this, an assistant squeezes the rebreathing bag with the valve closed whilst you listen for gas escaping from around the ET tube, adding just enough air to the cuff to form a seal. This ensures that pressure within the cuff is not excessive, as this can damage the trachea. Let's take some time out here. Before we use our anaesthetic machine, we'd better check it. Okay, so we're going to do a quick video on how to check an anaesthetic machine. And the three things I'm really looking for are, I'm looking at our oxygen supply, I'm looking at our volatile agent supply, and we're going to check the integrity of our breathing system. So this is a machine connected to the pipeline, so I'm just going to check that the machine is connected into our terminal outlet here, which it is. We're then going to go to the flow meter and turn our flow meter on. And we're going to check that the bobbin goes all the way up to the top of the flow meter, all the way back, and turn it off. Now we also have nitrous oxide on this machine, but we don't actually have it connected, so we don't need to check that. The next thing I'm going to check with regards to the oxygen is the oxygen flush, and that button is located here, just above the common gas outlet. Take the breathing system, just going to check that yes, indeed, our oxygen flush does actually work. Then we're going to come to our vaporizer. We're just going to check that the vaporizer is attached to the back bar. It is locked on. This is a select detect fitting, so you can lift the vaporizer on and off. Just looking at the levels, the vaporizer is full, but it's not too full. It's really important not to overfill vaporizers. And, okay, my oxygen isn't running, so there's nothing coming out of the vaporizer. I'm going to check that it does switch on and the dial moves all the way through the excursion it's supposed to move through. Okay, so I'm happy with my vaporizer, I'm happy with my oxygen. Let's move on to the breathing system. We're using a circle breathing system for our patient, so I'm just going to check that all the connections with the hoses are tight, the valves are tight, and that our APL valve works correctly. We've got our rebreathing bag there, and we've got our little cap on the top of the breathing system so we can check the integrity of the breathing system if there are any leaks. Just going to close that valve, push my oxygen flush, and check that my bag inflates. And we really want to check that that inflates for 10 to 15 seconds. And that's looking pretty good to me. The last thing I'm going to do, and the real safety check here, is making sure that that APR valve is indeed open. And that's it, we're done. So far we've considered pre-medication and induction of anaesthesia. If you'd like to see more on analgesia, please take a look at the previous module on analgesic techniques for cruciate surgery. We're now going to turn to look at the role of maintenance agents such as isoflurane and sevoflurane in balanced anaesthesia, and look at some of the advantages of isoflurane first. The volatile agents, of which isoflurane is the most commonly used, provide unconsciousness and muscle relaxation, but no analgesia. If you've ever tried maintaining anaesthesia with just a CRI of propofol or alfaxolone, you realise just how much muscle relaxation the volatile agents provide. This is due to their action at the level of the spinal cord. The great thing about volatile agents is they undergo minimal metabolism and are eliminated via the lungs, allowing for a quick recovery from anaesthesia. The volatile agents are particularly easy to titrate, and you'll appreciate the rapid alteration in depth of anaesthesia from changing the vaporizer setting. To illustrate the point of changes in concentration, take a look at the difference the breathing system makes. This is an important point in understanding how to make rapid changes in depth under anaesthesia. In the videos, we are measuring end-tidal isoflurane, how much the patient is breathing out, which equates closely to the concentration in the lungs. When using a circle breathing system, we have a greater volume within the system and typically use lower fresh gas flows. For the first 5 minutes, we use a higher fresh gas flow to denitrogenate the breathing system. If we start with an oxygen flow of 4 litres per minute and a vaporizer setting of 2%, just take a look at how long it takes the end-tidal isoflurane to reach the vaporizer setting. This video is 1 minute long, and we've only reached an end tidal level of 1.3% with a vaporizer setting of 2%. When using a circle system, we should consider this during the transition phase. To draw a direct comparison between a rebreathing and a non-rebreathing system, in this next example, I've used a vaporizer setting of 2% and a fresh gas flow of 4 litres per minute when using a Mapleson D breathing system. You can see how rapidly the isoflurane levels increase in this non-rebreathing system. One thing we do need to be careful of here is that our patient doesn't end up too deep. The volatile agents cause vasodilation and decrease cardiac contractility. This vasodilation reduces blood pressure and therefore reduces venous return. In combination with the reduction in contractility, the overall effect is a decrease in cardiac output. We always aim to reduce the percentage of inspired volatile agents, and do so through a combination of pre-medication, cautious use of our induction agents, administration of analgesics, local anaesthetics, and close attention to our indicators of anaesthetic depth. To illustrate some volatile agent sparing options, we'll finish this module with some cases. In this first case, the dog is undergoing a femoral head and neck excision for hip dysplasia. The dexmedetomidine and methadone PREMED gives us an excellent degree of sedation and analgesia, which will give a max sparing effect as well. With an epidural of local anaesthesia and morphine, there will be no reaction to surgery, and we should therefore pay close attention to signs of depth and decrease the inspired isoflurane accordingly. A spinal needle is to be used, which is advanced perpendicular to the skin. After skin penetration, the stylet is removed and a drop of saline is applied to the hub of the needle. This is then advanced until a popping sensation is felt as the ligamentum flavum is penetrated. A test injectate of saline is then injected. Note the bubble of air in the syringe. This should not compress when pressure is applied to the syringe. The solution to be injected is attached, and with very gentle pressure the injection begins. Administration should be over 30 to 60 seconds. The needle is then withdrawn. Taking us back to the previous example, I've given the doses here used for the CAT O tube placement. This combination gives excellent sedation and analgesia, and therefore we need very little isoflurane for maintenance, approximately 0.5%. When I mention isoflurane vaporizer settings, we are of course reliant on having our vaporizers serviced annually so we can guarantee the exact output. Thanks for joining this module on tips for a smooth and stress-free anaesthesia. I hope you find this useful for your next anaesthetic. You may also find the further reading on the next slide useful.
Thank you very much, Matt, for sharing your expertise with us. Hope you found it useful. Please take the VetSpace multi-choice quiz to reinforce and consolidate your learning.